Okay, we're going to get started. Today we'll be blessed with Matt Brennan, who is our chief fellow this year, who will be giving his talk looking at these combinations of aortic valve and anticoagulation issues that are pretty interesting. I think hopefully you'll enjoy the talk. Matt did his original training back as first a fellow in, or his undergraduate training was in psychology and biology, and then went on to Mississippi, progression or regression, I don't know which, for his medical school degree, University of Chicago for his residency, and then off to Duke for his fellowship. He's in his fourth year here as a fellow. He's also getting a master's in public health at UNC. Matt has actually been despite my comments to the contrary, has been a pleasure to have around here, and it's been a remarkable inspiration in certain ways, the way that he can look at data and his desire and joy he gets from it is a pleasure to see. So, Matt.
All right. Thank you, Eric. And thank you all for giving me an opportunity to present some of the data that we've one of the lines of investigation that we've been pursuing over the last couple of years. Let me just emphasize before we get started that this data is the product of multiple groups and multiple people. So although I'm presenting it, I can't claim it as my own in full. So today we're going to talk about a line of investigation looking at the safety and effectiveness of anticoagulants following aortic valve replacement surgery. And I was hoping one of my colleagues who's a fish doctor would be here so I could make this slide for him. But if your profession is fish doctoring, you will not get much out of this talk because it will be clinically focused, as we hope that most of our research is over here. So this is a slide put up here for Dr. Tricocci. I think it's probably the most cited slide or the most used slide in America these days. Is typically used to highlight the need for evidence accrual in various areas within cardiovascular medicine. As I see it, it's a slide to highlight the poor state of evidence in valvular heart disease. As you can see, valvular heart disease level of evidence A guidelines are less than 1% of the guidelines. And hopefully, thank you to Dr. Tricocci for years of clearing the way for years of funding for us in the future. So today we'll talk about some background of aortic valve disease for the non-clinicians in the audience, aortic valve replacement surgery as well. Then we'll get into some of the particulars of a project that we've been working on for AHRQ as our sponsoring agent, looking at various anticoagulants following bioprosthetic valve replacement surgery in the early period and the effectiveness of those using an observational database. And then we'll talk about some of the practicalities of using warfarin in specific in the post-BVR period, and then a bit about the alternative anticoagulant strategies as well as agents and sort of a view toward the future. At the end of this, I hope that you'll have an understanding of the literature and the landscape around anticoagulants in valve replacement surgery. I hope that you'll understand some of the limitations a little bit better of some of the anticoagulants, particularly as they apply to post-aortic valve replacement patients, and then something of a vision for where the trial landscape, anyway, may be moving in this area. So to get started, valve disease comes in two flavors. This will be a little bit of a review for the clinicians in the audience, but the first flavor is aortic stenosis. This is typically an acquired and degenerative process such that the valve develops, actually ossifies, so develops bone within the leaflets of the valve. Valves are what keep the blood moving in one direction out of the heart. And shown here is the calcium deposits and actually bone deposits on the aortic valve. The other form of aortic valve disease, of course, is aortic insufficiency, and this can happen in a variety of different ways, primarily either through dilation of the aortic root or through degeneration of the valve itself, where it becomes incompetent and the blood rushes back from the aorta into the ventricle, causing a volume overload situation in the ventricle. Aortic valve disease is a prevalent condition, and its prevalence increases as we age. So patients in their fifth and sixth decade of life start to show up with aortic valve disease and symptoms from aortic valve disease, and once you get over 75, roughly 7% of the population is expected to have prevalent aortic valve disease. Particularly aortic stenosis is an indolent disease, meaning that for a long period of time you may go without anybody telling you anything, but you have a murmur. And then all of a sudden, so over time, your valve is slowly closing down or getting more regurgitant. And over time, as eventually you meet a critical state, so either a critical obstruction or the ventricle stiffens enough, or a combination of the two, that you become symptomatic. And your progression at that point is dictated primarily, or it correlated highly with the type of symptoms that you have, such that if you present with shortness of breath, with heart failure symptoms, your expected survival is roughly 2 years. So 50% of the population will be dead within 2 years of presenting with shortness of breath from aortic stenosis. The bad news is that there is no medical treatment for aortic valve disease. The good news is that there's an excellent surgical treatment for aortic valve disease, and that's aortic valve replacement. If you survive the surgery with aortic valve replacement, your expected survival is roughly equivalent to that of a background population of age and sex-matched cohort. So the surgeons are doing a nice job. Not completely equivalent, but very, very close. There are two types of prostheses that we use. When the surgeons replace the valve, they use two different types of prostheses. One is mechanical, the other is bioprosthetic. The mechanicals were the first to market. They have incredible longevity. Most of these outlast the people in whom they're placed. So you can have a mechanical valve for years and years and years, and it will keep on ticking. Generally, the problem with these mechanical valves is that they're metal. Metal inside arteries, we know, doesn't work real well. So it tends to thrombose. So people present without anticoagulation would present with valve thrombosis and thromboemboli. In response to this, bioprosthetic valves were developed. And bioprostheses are valves that either come from harvested from a pig and treated and put in people, or they're crafted from the pericardium or the sac around the heart and put into folks. The upside of bioprosthetic valves is that they don't need long-term anticoagulation. The downside is that they tend to deteriorate. So you can expect a bioprosthetic valve to last for somewhere between 10 and 20 years. Where exactly it's going to last depends on the valve, and when patients ask us, we typically say, I don't know. So somewhere around 10 to 15 years, they tend to deteriorate. But as these valves, as the bioprostheses have gotten better over the last decade, as the patients who are needing the valves have gotten older, and as the risk of reoperation has gone down, bioprostheses have taken over the market and today represent 80% of aortic valve prostheses that are placed, which is different than the past. This is data from the STS database Dr. Brown published last year. We'll spend the remainder of the talk focusing primarily on bioprosthetic valve anticoagulant issues, and at the end we'll talk a little bit more about mechanical valves. We'll start with this question of the effectiveness of anticoagulants post-bioprosthetic valve placement. So we know that in the early period after a bioprosthetic valve is placed, there is an elevated risk of thromboembolism. It's been well described. This was the first paper to look at it back in 1995 and showed an initial very high peak in thromboembolic risk, followed by a period out to 90 days of an elevated risk of thromboemboli. And the thought is here that clots are forming on that apparatus, the structural apparatus here, this white area here, the structural part, and until that has a chance to endothelialize, that valve will be at higher risk for thromboemboli. That takes out to at least 3 months, some people say out to a year. So the question, in recognition of this risk, the ACC-AHA guidelines have responded to that by placing a Class 1 or 2A recommendation for warfarin therapy in the first 3 months after bioprosthetic valve placement. This is a very controversial decision by the guidelines, the updated guidelines. They divide the population of patients who receive bioprosthetic valves into those with additional thromboembolic risk factors and those without. And those with risk factors are folks with atrial fibrillation who have an indication for warfarin anyway for lifelong therapy. Those with a prior history of some sort of thromboembolism, a known hypercoagulable state, or what is debated but is in the guidelines is an ejection fraction less than 30%. Any of those folks, they say lifelong warfarin is indicated. For folks without any of those additional risk factors, the guidelines still give a Class 2A recommendation to warfarin therapy for the first 3 months until that stent that structural apparatus has a chance to endothelialize. And they appropriately classify these as level of evidence C. So back to Dr. Tricocci's article, this plays in. And I think that that's an appropriate recognition of the poor evidence in this area. So there are a total of 2 randomized clinical trials. 260 patients roughly have been randomized in this area. Across those 2 trials, this is the largest of the 2. And the conclusions of the authors in this publication were that there's no statistical difference in either reduction in thromboembolic risk or increase in hemorrhage, which we all know to be, at least the hemorrhage part, to be somewhat hogwash. But you can see here that there are differences. The question is, were these adequately powered? And the answer is probably not. In recognition of this poor evidence, practice patterns vary widely on what surgeons or cardiologists tend to do with these patients after surgery. So these are post-bioprosthetic valve patients for the first 3 months. This is a survey by the CTS Net group, which included both U.S. and non-U.S. sites. And the first thing that I'd like to point out is how divergent physicians' opinions are here. Roughly 50% of the surgeons that were polled said that in none of their patients should warfarin be used. 0 to 10%, almost never should we use warfarin therapy in these patients. Another 30% feel just as adamant that we should use it in everybody. So hopefully this points out to you some of the equipoise, first of all, that surrounds this issue, and secondly, that this decision is being made primarily on physician preference and not as much on patient characteristics. And that'll play out in some of the data that we see. So the question here was, what's the risk-benefit profile of warfarin in addition to aspirin in this patient population? AHRQ commissioned the study. And our principal investigator was Dr. Peterson, along with Dr. Douglas and Dr. Edwards, and a very capable statistical team with some strong administrative support. So the specific aims here were to describe in the United States what are the practice patterns for use of anticoagulants. The second was to look at both ischemic and hemorrhagic events. What is the risk in this population for the first 3 months? And then to look at the safety and effectiveness of different anticoagulants. Finally, we wanted to evaluate for meaningful differences in the safety and effectiveness of the anticoagulants across strata of age, sex, and thromboembolic risk. In the study, to do this, we turned to the STS database. So, as you guys probably know, here at the DCRI, through much of the work of Brad Hamill and Leslie Curtis's group, we have linked many of our registries to Medicare data. So patients who are collected in what are traditionally cross-sectional registries now have longitudinal follow-up in the elderly patients. So patients who are fee-for-service over 65 can be included here, and it's provided a tremendous resource, and hopefully this study will highlight one of those resources. We excluded patients with stentless bioprosthetic valves. Those are ones without the support structure. It's a minority of the patients treated, less than 2,000 of the patients treated, and those patients are believed to be at a different thromboembolic risk. And our final study population was about 26,000 patients. So I told you before, the randomized data is about 250 patients. This is about 26,000. Of those, about 18,000 receive either aspirin or aspirin plus warfarin. We divided those populations into patients who have risk factors and those without risk factors according to the guidelines. So the first finding here is the practice pattern. So they're divergent dependent upon whether or not you have risk factors or you don't have risk factors. Among patients without risk factors, roughly 25% of those patients were treated with warfarin. And that fits pretty well with what we saw on that CTS Net slide. Among those with risk factors, surprisingly, only about 50% of patients were treated with warfarin. I say surprisingly because I'll show you the reasons why these patients, the risk factors that these patients had. The propensity distributions of these groups, so the propensity of getting both warfarin and aspirin, so getting warfarin therapy, the distribution appeared to be very similar across patients who were treated with aspirin only and patients who were treated with warfarin plus aspirin, suggesting potentially that the treatment bias here will be limited as we look at it, that the characteristics of the patients are fairly similar across the groups within the risk factor negative and risk factor positive populations. There was very little non-overlap in these distributions. And this plays out in the patient characteristics. I'll give you a few of them here. Across aspirin and aspirin plus warfarin, so across your treatment groups within risk factor negative and risk factor positive populations, the patient characteristics are fairly similar. And I hope you can appreciate that from this, with the exception of patients undergoing CABG surgery, which tended to be more likely to get warfarin therapy. Complications, postoperative complications, were similar across treatment groups and tended to be more common in the risk factor positive patients, suggesting that these risk factors are also markers of complications or of increased procedural risk. And then finally, if you're the interest in who are these risk factor positive patients, 80% of them roughly had atrial fibrillation, which is why I say that it's somewhat surprising that more didn't get warfarin therapy. Roughly 30% had prior thromboemboli, most of which were CVAs, and these are, and then roughly 10% had an ejection fraction, so a minority, less than 30%, were included in that group. So these are the unadjusted event rates, the incidence of events over the 3 months that our study of our study period, of our follow-up. This is 0 to 2.5% incidence rate. You can see at the top, these are ischemic events and these are hemorrhagic events. The green bars represent the risk in an aspirin cohort. The red bars represent the risk or the incidence in an aspirin plus warfarin cohort. And you can see that among ischemic events, for the ischemic events, the patients treated with warfarin had a lower incidence of ischemic events. You can see that also that most of these ischemic events were strokes rather than TIAs. And then within the bleeding, so warfarin causes bleeds. We know that. Most of those bleeds, though, are GI bleeds, and that's important to take away from this slide. The vast majority of the bleeds that we saw, there was a smattering of hemopericardium, and very rarely did we observe hemorrhagic CVAs. So less than 1% of patients presented to the hospital were rehospitalized with hemorrhagic CVAs, and there was no difference between the aspirin and the aspirin plus warfarin groups. These are the primary results of this first study, and I'll just walk you through them here. This is a comparison, again, of aspirin plus warfarin versus aspirin only, and what we observed is that patients treated with aspirin plus warfarin had a lower risk of death and ischemic stroke, a higher risk of hemorrhage. And to put those in population numbers for those of us who treat these patients using number needed to treat and number needed to harm, it takes roughly, we'll focus on ischemic strokes here, this is risk factor negative, risk factor positive, it takes roughly 200 patients treated on average to prevent one ischemic stroke, and roughly 50 patients treated for an association with one bleed. So hopefully this furthers our discussion with patients. So if we talk to patients after a valve replacement surgery, what we can say to them is that this is about a 1 in 5 ratio. So for every 1 stroke prevented, we're going to need to cause 5 bleeds roughly. And most of those strokes will be true strokes, not TIAs. Most of those bleeds will be GI bleeds, not hemorrhagic strokes. And that's a conversation. This isn't most of these studies are not slam dunk conclusions. So the question is, for the patient in front of you, what is their value system? And I'll tell you from the literature that exists in patient utilities, it would suggest that most patients would choose a GI bleed over an ischemic stroke. But this is data to further that conversation, hopefully. We looked within subgroups of age and of sex for the death benefit that we saw with aspirin plus warfarin seems to be consistent across subgroups. For the ischemic benefit, it seemed to be consistent across men and women, but perhaps is more localized or more apparent within the older patients, which is interesting because these are patients that we think about traditionally as we would be less aggressive in our anticoagulation. This data suggests that we ought to be more aggressive in our anticoagulation of these patients, and this is a trend that we've seen in ACS treatment. We've seen it in other areas as well. And for hemorrhage, there did not seem to be a significant interaction based on sex or age. So what are the limitations of this study? So first of all, we use discharged anticoagulants. We have information on the patients, what they left the hospital with. We don't have day-to-day, did they take their medicine? We don't have, did they continue their medicine for 3 months? We do know from the ACTION survey, however, that the majority of patients who are discharged on vitamin K antagonists, their intention to treat is for 3 months. the vast majority, this is 95+% in the ACTION survey. We don't know the target INR range for these patients. Again, turning to the ACTION survey, tends to be within the guideline recommendation, so an INR of about 2.5. This is a Medicare-linked cohort, so the question of generalizability comes up here. And certainly these patients are all elderly, over 65, but remember I told you that one of the problems of bioprosthetics is that they tend to deteriorate. The majority of patients who receive bioprosthetics are elderly patients. This is our target population, so I would challenge the question of generalizability also to turn to some work that's been done by Jeff Jacobs in this, looking at this database and the generalizability of this database set to both Medicare, the overall Medicare fee-for-service population, as well as the generalizability to the overall STS population. It appears to be the populations seem to have incredible overlap. Finally, we use, inpatient claims follow-up. So the question is, are we underestimating events? So some patients who have strokes, do they not come to hospitalization, or bleeds, do they not get admitted to the hospital? We may be underestimating events, but we do expect that that's non-differential across treatment strategies. So I have no data to suggest either way whether or not this is differential across aspirin or aspirin plus warfarin treatment. And finally, there is always the 300-pound gorilla in the room, or the white elephant, or whatever you want to call it, in the room when you do a study like this, which is treatment selection bias, which is, in this case, the question is whether or not patients who receive aspirin plus warfarin, we know clinically in other areas when you use patient characteristics to determine anticoagulants that we're less aggressive about anticoagulants, and perhaps we're less likely to give warfarin to frail patients. That may cluster our frail patients within the aspirin-only group, and so bias these findings against aspirin only. And to look at this, because we were concerned about this, we did a sensitivity analysis. I'll show you the results of that. We chose a population of patients, roughly 60 to 75% of our population, that was discharged directly to home. So we know clinically that patients who are directly discharged to home are somewhat different than patients who stop by rehab on the way. So patients who go directly to home tend not to be frail, and in this way we've restricted our population, hopefully to a patient population of less frail patients, to get this out of the picture, and looked at the results, and the results are almost identical. So hopefully suggesting that, and this feeds back to that slide that I showed you, which suggested that this decision is actually made based on physician preference and not so much based on characteristics of the patient. So summary, warfarin is used in a minority of patients post-BVR. Warfarin use at discharge is associated with lower ischemic events, but it carries a substantial bleeding risk. And then finally, the safety and effectiveness of warfarin seems to be independent of sex and thromboembolic risk. Stroke reduction may be more apparent within the oldest patients. So the message here is that after bioprosthetic valve replacement surgery, there is an elevated risk, and that risk is modifiable. Now we'll talk a little bit about whether warfarin is the right agent to modify that risk. And to answer that question, we looked at the ANSWER registry, and this is a registry that was sponsored by St. Jude Medical Company. It had about 380 patients in it, with about 40 centers enrolling, and it included any patient who received an initial valve replacement planned with one of St. Jude's valves. So that's why they funded the trial. In the mitral or aortic position, and we collected, the folks who ran this collected outpatient INR logs and audited adverse event data. And these are the primary findings, which is, first of all, time to therapeutic, the median time to therapeutic INR level is about 9 days in these patients. Remember, I told you that the risk is very much localized within the early part of that 3 months. So 9 days median time to therapeutic. 20% of patients treated with warfarin in a post-BVR population remain out of range beyond 4 weeks. And the vast majority of those patients, once they come in range, are then moving out of range. So there's a tremendous amount of fluctuation in this population. It results in about 40% of the person time of these patients being spent in range. So about 60% is spent out of range with warfarin. And this has real consequences. So as your proportion of time spent, this has been shown in other populations, but now in a valve population, as your proportion of time spent out of range increases or supratherapeutic increases, your risk of hemorrhage also increases. So why valve patients? Why do they have such problem with warfarin dosing? This is a study that was just released within the last couple months. This group looked at a control group of patients who had new onset atrial fibrillation and were treated with warfarin therapy. Initial dose tended not to vary over the first 3 months with a mean INR in range. Within the valve community, although the mean INR stayed in range, the dose needed to be escalated for the first 3 months. You can imagine that that's less than ideal for a drug which has an indication for 3 months. You never reach your target dose on average in this population. And the authors put forward a couple of hypotheses. One is an issue of metabolism of warfarin in the post-BVR patients, whether their livers have taken a hit and it just takes them a while to metabolize the drug. The other is new drugs in addition, so things like amiodarone, et cetera, being thrown into the mix. And then finally, patient diet picking up. In any case, patients post-BVR don't tend to do well with warfarin, as well with warfarin therapy. So warfarin management is particularly challenging in this patient population. So the final part of this talk, we'll talk about alternative strategies and potentially some alternative agents, and then we'll open it up to questions in a bit. So alternative strategies. The real alternative strategy here that's been proposed is home INR testing for patients. This standard of care in parts of Europe. It admittedly takes a very select population of patients to be able to monitor and adjust their warfarin doses at home. But if you can find that select group of patients, it tends to make a modest difference in the time spent in range. So slightly better, slightly more time spent in range among these patients. In terms of novel anticoagulants, you guys have seen this slide hopefully a couple of times. Thank you to Dr. Becker for sending it on to me. But there are a number in the pipeline. An ideal agent in this population would be an oral agent. And there are several that are coming down the pipeline that may be possibilities. All of these agents will need to be tested in a valve population. The population, hopefully I've convinced you, is different enough. So designing these trials, so that's the last thing that I'll leave you with, is fairly complicated. We've been going through it recently for Boehringer Ingelheim. And the question comes up, what population do you choose? So do you choose a bioprosthetic population, which has an indication for 3 months, or do you choose a mechanical valve population? Admittedly, it's a smaller group of a proportion of the population, but these patients are going to need this treatment for lifelong therapy. Do you then restrict a valve subtype? So we know within even the mechanicals or the bioprostheses that your risk is very much dependent upon the type of valve that you receive. So in a trial, do you restrict that? Do you look at risk factor positive and risk factor negative patients, or do you look at one or the other? And do you choose patients who have never had warfarin before? So if you do, potentially you bias the trial in the favor of your new anticoagulant and against warfarin. If you look at warfarin-tolerant patients, certainly you bias the trial against your new agent. And it's more applicable, warfarin-tolerant to patients who have been on warfarin therapy for these valves. Over time, your control group, what is the standard of care? So hopefully I've shown you here that there's divergent opinion on what is the standard of care, both for bioprosthetics and for mechanicals. Do you choose, in this case, if you were to do bioprosthetic valve trial, would you choose aspirin or would you choose aspirin plus warfarin? What doses would you choose? And endpoints, this is sort of an age-old ACS question, do you decide to combine bleeding and thromboembolic endpoints? If you do, your event rate will be higher, potentially your power will be higher with the same population, but you risk losing a meaningful effect. And then finally, do you go for a superiority trial or for a non-inferiority trial? And if you do choose non-inferiority, what's the margin of error for mechanical valve populations? It would be unethical in today's practice to compare warfarin versus aspirin only for mechanical valves. And this is the trial that we spoke to. So that is the majority of my talk. I wanted to take a minute here, gone through it reasonably fast, and just wanted to take a minute here on the stage to say thank you to my co-fellows for making your friendships and for making this a productive time. And you've taught me a ton. My mentors, and that includes not only current fellows but also my chiefs, John and Renato from last year. Mentors, obviously Dr. Peterson has been my primary mentor and has taught me a tremendous amount. Without going any further on that, Dr. Douglas has guided my career as well on the stent side. In statistics, much of my knowledge that I've gained has been due to our fabulous statisticians here at the DCRI, and I think that's true for all the fellows. So much of what I know today is because of their patience and sort of pounding me over the head every time I ask them the question for the 15th time. And a particular thanks to folks even who were not involved with these directly with these analyses. And then to Dr. Benjamin and Dr. Rowe for making the last year a good year, and to Patsy for helping me through the administrative details of being chief. And finally to funding agents, so to Dr. Mark, who's back in the back, for agreeing, somewhat reluctantly, but agreeing to put me on his T32. Thank you to the NIH for their money through that. To UNC for funding about half of my tuition over there, and to the folks here at the DCRI who picked up the remainder of it along with the T32. And I have to say I went into this sort of reluctantly, to some extent, the degree over there, because I was a little bit concerned about finances. But over the last 2 years, I've had not one sleepless night, not one time when I needed to worry about whether or not the funding was going to be there to cover tuition, and that's been an incredible resource, and I'm very appreciative to that, and to HRQ for funding much of the work that we've done. So that's what I've got, and I'll open it up to questions on the project, to potential ideas for the design of this study that we mentioned. We would certainly appreciate input on any of this. So thank you.
Hey, Matt, that was a great presentation. I had a question about, kind of applies to this as well as other areas of comparative effectiveness. What do you think is the threshold for these being used for, or these types of studies being used to change guidelines? And do you think, say, the work with the valves and anticoagulation has met that threshold?
Yeah, no, it's a great question. The question comes down to what is the level of evidence that you ought to put here? Does it change the guidelines yet, potentially? Should it be viewed in the same light as a randomized trial? I think they're different. And is one superior to the other? No, I don't think so, but I think they're different. Should this be used to direct the guidelines? Yeah, I think so. What is the threshold? I think the question is, can you do this in a clinical trial, first of all? If you could do it in a clinical trial, do we have the ability to make it an inclusive and a pragmatic clinical trial? Probably not in today's world. So is this better than I'm treating patients based on my sort of dogmatic approach to what patients ought to have? Yeah, I think this is better. Should it inform the guidelines? Yes, I think it should inform the guidelines.
So the reason I was asking is because some of those results were pretty impressive, almost too impressive for some endpoints. So, and you still wonder whether, say, relate to ischemic stroke, whether the risk reduction is that still in part a selection bias or not? We've had those problems with some of the other work we've done, where we're still uncertain about, whether, even though we've had what we feel is a robust analytical approach, is it too good to be true? And so that's like, what are the next steps in terms of helping, say, validate these findings, or trying to show that this is a real effect?
Sure. So I'll start with the next steps. I suppose part of that question. Certainly, we always say you could replicate another database, although if you look at the stent mortality, the DES mortality finding that we had recently, that was replicated in 10, 15 registries now, And do we believe that that's bias versus the effect of the stent? I don't think the replicating it in 10 to 15 registries has changed my opinion on that. So I think at the end of the day, you look at the data. So you look at the propensity distribution overlaps, try to see is there, let the data try to tell you is there a treatment selection bias. You look at your clinical knowledge, whether or not this is based on clearly a patient bias in who you choose for the treatment, and do you have those variables to adjust. Our clear thought here in terms of where the bias would come in was that, as I said, was that warfarin would be given to less frail patients. And I think we've taken the step to look and see in a patient population then restricting as best we could on non-frail population, are the results robust? If you start to see divergent results as you do that, then I think it's got to make you question. If you see consistent results, then I think it increases your confidence.
So I'll take it even a step further. I mean, partly here, the treatment selection bias on the patient level is relatively modest, almost non-measurable, at least in the measurable variables we have. If you look at the baseline characteristics of those treated versus not, they look the same, basically. And the answer is it's shifted mostly by what we know in clinical practice. What does the surgeon want to do for these patients in general? And that's what they do in general to most all their patients. So when it's all up to the serendipity of which surgeon you have, then the degree to which you recapitulate randomization is higher. Now, it's not complete, but it's higher. B, you would think that at least, who would you use warfarin in? Would it be in a patient who has a higher or lower pretest likelihood of having a stroke? You would hope that surgeons or clinicians would tend to use warfarin more likely in a population in which we're more likely to be at risk for stroke, and therefore the subtlety there ought to be a bias against the effect of warfarin for preventing strokes, not the opposite. So if anything, you could argue this is an underestimation of the potential benefit of this therapy relative to what you might see in a randomized clinical trial. And then the final thing is it generally believable? And here, I don't think there's anything here that doesn't replicate what's been shown in randomized trials of atrial fibrillation and other conditions where there's embolic potential. You see a reduction which is marked in patients who receive the drug. You see increases in bleeding which are equal to, and that's exactly what it even for that matter replicates the 96 patient study for that matter. The exact findings, sort of an increased risk of bleeds and a decreased risk for strokes that just in 96 patients wasn't significant. So everything to me would say these results probably are believable. Would I want a randomized trial? That's where I differ. I would say absolutely. And I would argue a little bit with Matt that it's not feasible. This is the setting for which if there is no data and it's purely up to physician preference, that they ought to be willing and able to do a practical randomized study.
Matt, so I enjoyed your presentation. I came in a little bit late, and I saw your poster presentation of some of the same data at the Cardiovascular Symposium. My question has to do with the significance of the subgroup that, what I see as a subgroup that you honed in on, and that is the bioprosthetic valve population. Your risk factors are your major risk factor is atrial fibrillation, which is in a sense, for most of these patients, a class 1A indication for anticoagulation anyway. Sure. And I wonder if you've looked at the same results in the non-bioprosthetic valve population who stratified risk factor positive, risk factor negative, and see whether you see the same effects of those who use warfarin versus those who don't.
So in the mechanical valve population?
No, how about in coronary artery bypass surgery population who don't get a prosthetic valve, who don't have a prosthetic valve? Because you might, based on what we know about warfarin and its effect on thromboembolism, you might expect in atrial fibrillation, in a high-risk atrial fibrillation population with at least a couple CHAD scores, you might expect similar results.
Yeah, I think it's a good point. No, we've not looked at that. Just to speak to it a little bit, so within the risk factor positive population, This is a group that not only had atrial fibrillation pre, but also we screened for atrial fibrillation post. So post-op atrial fibrillation, if it occurred in hospital, should have been captured in this risk factor positive population. And the risk factor negative population should be the group that you referred to, those without atrial fibrillation. However, we all know that if you're going to have post-op atrial fibrillation, it doesn't necessarily occur in hospital. And would we have missed some of those patients in this risk factor negative population? Sure, potentially. But I think that this is probably the group that you referred to, and the results from the risk factor negative patient population should be the patient group, the risk reduction in a patient group without additional risk factors. So. Dr. Crane?
Matt,
yes,
that was great. Thanks, and congratulations on doing this. I think as you pointed out, the lack of evidence, the fact that one of your key references was from 1968, when Karen Pieper was like in diapers, speaks to the need for anything in this area is so important, I think, to help inform us. I think, as you know, I personally think the main value of this is to illustrate the fact that we really desperately need the reliable data from randomized trials, that the confounding, no matter how much we try to account for it, is the unmeasured confounders are the key, and you can't adjust for it. Yep. But I do wonder, having said that, I think we're still all interested in it. And because of this phenomenon that the surgeon is such an important instrumental variable in this whole thing, what happens when you don't look at the patients, but when you look at the surgeons, according to their use of warfarin or aspirin and their outcomes? And maybe we should just not be using those surgeons.
Yeah, perhaps perhaps, so it absolutely could be that all of the worst surgeons leave patients on aspirin only, and the best surgeons leave patients on aspirin plus warfarin. I think that's unlikely, but it's possible. Certainly you could do the essence of a cluster trial here, looking at per surgeon or an analysis on the surgeon level in an ideal world.
There might be political challenges there, huh?
In the STS, it's not been done thus far. Yeah.
Yeah, it wouldn't be. It just might be another way to look at the overall picture. If it turns out that those, it still doesn't completely adjust for the fact that some surgeons may get referred higher risk. So it's still going to be won't take care of the issue, but it'd be just another way to look at it.
Yeah, you know what makes me think that this is more. This decision, we talked about this. This decision is really based on surgeon preference. But do I think that these 50% of surgeons are somehow worse surgeons? Well, look at our surgeons at Duke. So Glauer is a great example. Does not put any patients, hardly, on warfarin following bioprosthetic valve replacement surgery. Now, would you argue that he's somehow inferior? Probably not. And do I think that cuts across this? I don't have data to suggest that it does or doesn't. That's an N of 1. But it's a good point. It could be. I'm going to go with seniority. Dr. Mark, roll the dice here.
I also apologize for coming in late, and you may have already provided the data. Dud microphone to see if the old guy even notices.
We asked the AV folks to actually turn it off.
You may have already presented this data before I came in, but following up on Chris's question, the sort of distribution of usage patterns by surgeon, and whether there are, whether Dr. Glauer is a prototypical example, which is an all or nothing kind of bimodal distribution, or whether there's really something much more spread out in terms of patterns of use, and how that affects the thesis that you were forwarding a moment ago about the sort of all or nothing thing, clustering sort of as a confounding issue.
Within this database, thank you for asking the question. Within this database, we have not looked at the issue. The question within practice patterns, the CTS-NET group, This is some data that I showed earlier. The CTS NEC group did look at this, and they surveyed surgeons, and they asked them specifically among patients without risk factors, what proportion of those patients in your practice do you think should be on warfarin? What proportion of those patients do you think should not be on warfarin? And it is absolutely a bimodal distribution. So by and large, physicians either believe that all of their patients or nearly all of their patients ought to be on warfarin or ought not to be on warfarin. 50% here said that they would never see a circumstance in a post-BVR patient without other thromboembolic risk factors that they would ever use warfarin. And 30% feel just as strongly that they should always use it. So, A, it speaks to the equipoise, but B, it also speaks to the bimodal distribution that you were just commenting on.
Thanks. That was great. I was just going to ask, I was struck by how this is so similar to some of the other stories we've heard about DES and other drug therapy, and you're saying, at least here, that there's a decision that probably is very physician-based and not related to patient characteristics. Many of these patients have strokes from a lot of reasons. You know, maybe that warfarin's doing a lot of different things. It sounds like a lot of our AFib studies going on right now.
Sure.
You started with this mechanistic thing that it gets endothelialized within 3 months. Do we have actual data of that? And then do we know if these surgeons that really want to use warfarin use other things that are probably markers of good care also?
That's good.
Statins and LEMAs and other things that may affect patient outcomes.
Sure. No, it's a good question. The data goes back to 95. This is Harris data and looks at the risk for the first 3 months. And what they showed in that paper, and this is just a figure illustrating it, is that early, within the first couple of weeks post-BVR, that patients are at the highest risk, and that risk goes down. They've got animal data. We've got pretty good animal data that shows that endothelialization does occur, if not platelet lining of these valves, actual endothelialization occurs, and it's not just for the first 3 months. Most of it occurs in the first 3 months. There are some folks, just like with the DES story, that tend not to endothelialize these valves for up to a year, but the vast majority of patients are endothelialized by 3 months.
Like all of your stroke risk around bypass or any cardiothoracic surgery may be in this time course, do you think?
Yeah, sure, from day zero.
So any surgery procedure.
Would that be differential across aspirin versus aspirin plus warfarin? I don't expect that, and that's based on the data that I showed from in-hospital complications here. That stroke across aspirin versus aspirin plus warfarin was similar, thromboembolism similar across the two treatment groups. So that doesn't seem to be driving the decision, but is a valid question.
And we don't know if they use more effective other evidence-based therapies, some of these surgeons who believe in warfarin.
Yeah, no, I mean, the question that remains is this a surgeon issue? Are surgeons who tend not to use, back to this slide, are surgeons who tend not to use warfarin? Are their practice patterns globally different than surgeons who do use aspirin? And the answer is that I can't answer that question. The vast majority of patients we know from the ACTION registry, the vast majority of surgeons in that registry use some sort of a heparin agent in hospital, and they typically start those about on day 1 or so. They start, if they're going to start vitamin K antagonists, they start them on day 2. Other medications, are these surgeons, it's possible. It's I think it's less likely, but that's it's based on personal experience. I can't tell you in this particular database, so it's a good question. So that's all I got. Thank you guys for coming. I appreciate this opportunity.